This is the optimal management of patients with chronic heart failure in the community. I am Terry Diederich. I am a nurse practitioner at Nebraska Medicine in Omaha, Nebraska, and I've been caring for heart failure patients for the last 8.5 years.
And I'm Bunny Pozell, and I am faculty in the University of Nebraska Medical Center College of Nursing. And I'm a nurse practitioner at Bryan Heart Institute in Lincoln, Nebraska, and have worked with heart failure patients for over 20 years in the clinic there.
During our webinar today, we're going to be discussing a patient, John Smith, and how he does throughout his heart failure diagnosis and progression of his disease. Our learning objectives are as followed. We want to discuss the pathophysiology of chronic heart failure with reduced ejection fractions and the mechanism of action for the current medications we use. We also want to look at some emerging therapies and new management for heart failure patients. We want to work on how we assess clinical data for these patients and the treatment therapies that we determine for our patients. We'll be looking at patient characteristics and prognostic indicators for advanced heart failure, and also talking about some of the tools that we use within our everyday practices to evaluate our heart failure patient. John Smith is our patient we will be talking about. On initial presentation, he comes to your local emergency department. He's a 54-year-old gentleman. He comes in complaining of shortness of breath. He states he's been short of breath for about the past month. He's noticed he's more winded, he's more tired. Within the last week, this has gotten continuously worse. He now cannot walk a block without getting short of breath. On physical exam, he is hypertensive. He has a blood pressure of 196/102. He's also slightly tachycardic with a heart rate of 98. He's tachypnic. His oxygen saturation is also on the lower side. His weight is 256 pounds. On physical exam, he does have some jugular vein distension. He's got coarse breath sounds. His lower extremities show 2+ edema. And on his abdomen, he does have a positive hepatojugular reflex. John's medical history shows he does not have any significant medical history. He has not seen a primary care physician in the last 4 years, does not take any medicines, prides himself on being a healthy gentleman. He did have a tonsillectomy as a child. Socially, he drinks 2 to 3 beers on the weekend. He is a smoker, and he smokes 1 pack of cigarettes a day. Recently, he has become so short of breath, he is not smoking at all. His family history shows that his father died of a heart attack at the age of 62. His mother has hypertension and diabetes, but no other known cardiac history.
So obviously he has some risk factors there, where he had a father who died at age 62, and then the hypertension and diabetes. So both very important risk factors to be aware of. So this is actually the chest x-ray that we got on John. And one of the things you can immediately see as you look at it is that the heart silhouette is quite enlarged. The guideline for determining whether a heart is enlarged is whether it is more than half the thoracic diameter. And so you can see that this heart is obviously more than half of the thoracic diameter.
John's laboratory data on initial presentation shows that he has a white blood cell count of 12.2. His hemoglobin and hematocrit and platelets are all normal. His sodium is normal at 138. His potassium is normal at 4.8. His kidney function is elevated. His BUN is 42 and a creatinine of 1.62. As he hasn't had any labs in the last 4 years, we don't know what his baseline has been running, but this is elevated, which would cause me some suspicion of things potentially going on other than just the shortness of breath. Laboratory data also show that he had a pro-BNP of 2300, which is significantly elevated for a patient, which gives me suspicion that maybe something else is going on other than shortness of breath, and maybe he has pneumonia, or this leads me to think that there's something besides those things going on.
And one of the things to be aware of is that BNP, sometimes it's measured with a pro-BNP, which is actually about 5 times what just a regular BNP. So you need to be aware of what your lab actually is measuring, whether it's a pro-BNP or a regular BNP.
So when you look at John and you start thinking of differential diagnoses, things that initially pop to my head is this something infectious? Does he potentially have pneumonia, as his white blood cell count is a little bit elevated? He's short of breath. Something else that you could think of is, does he have malignancy? Is there some sort of cancer? He's been a smoker for multiple years, smokes a pack a day. Does this patient have heart failure? Your chest x-ray would kind of lead to the idea of potentially he has heart failure, as his heart is enlarged on x-ray. Potentially he has a COPD exacerbation. He has been a smoker for quite some time. He's complaining of shortness of breath. We don't have any pulmonary function tests on him currently to look at what his lung functions are. Potentially, maybe he has an arrhythmia that's causing some of the shortness of breath. His heart rate is a little tachycardic, but he is in sinus rhythm from when he came in, but I don't know. Potentially there's something else going on there.
It's important to think of all those potentials. Primary care hasn't seen him for 4 years, so we don't really know what may have transpired in that amount of time that could be potentially factoring in here.
So as a participant looking at this, what would you think would be your differential diagnosis for John?
And it's always good to generate all the kind of potentials that you think could be there.
When we start discussing looking at heart failure in patients, there are definite things that should lead you to believe that potentially a patient has heart failure. The cardiac abnormalities that you look at, so patients with heart failure would have elevated filling pressures. They have signs of fluid overload. On physical exam, you would see this as jugular vein distension. When you listen to the patient, they might have an S3 gallop. You can hear rales in their lungs. Many of these patients have hepatojugular reflexes. They have lower extremity edema, and some of them also have ascites. If you have an advanced heart failure patient, you could have someone that has anasarca, which is edema swelling all the way up to their navel.
So if we think about John, we said he had jugular venous distension. We said that he had rales. We also said that he had the 2+ edema. Mm-hmm. So that's all consistent with there being a cardiac underlying origin.
Further, these patients have signs of cardiac enlargement. So when you will actually palpate, you will feel a displaced apical pulse. When you listen, you also have signs of murmurs for valvular dysfunction. Many times patients with heart failure, when their ventricles dilate out, the valve actually stretches, creating a functional regurgitation of flow because of the size of the heart.
And that murmur will actually occur during systole, and you'll hear that between S1 and S2 and actually hear that murmur.
Many heart failure patients also have a reduced cardiac output, so they will have narrow pulse pressures. Sometimes they will have cool extremities. They can also become very tachycardic with pulsus alterans. And some of these patients also have arrhythmias, like we talked a little before. They can have an irregular pulse. They can also just be tachycardic, so signs of strain of the heart trying to compensate to create more cardiac output. So they run tachycardic heart rates in the 90s to 100s. So getting an EKG on these patients is also always helpful. So when we do an initial evaluation of our heart failure patients, we want to start first and foremost with an extensive physical and history. The best information you can get is from the patient themselves. Many times they will tell you things that are wrong if you take the time to listen to them. When I look at Mr. Smith's history to begin with, to me the most telling thing is that he's so short of breath that he's not smoking anymore. To me, patients that feel that debilitated that they can't do the things that they were doing before, it's something that you need to be looking at and following in their history. Once you've gotten that history and physical examination and you have a suspicion of heart failure, the first things that you need to do is assess your cardiac structures and your function. looking at echocardiograms, looking at the chest x-ray, all lead you down the line of heart failure. Once you know that the patient has a weakened heart muscle for some reason, you need to start looking at different etiologies of heart failure. You should pay attention to things that can be reversible. If a patient's complaining of chest pain and they have heart failure, it definitely warrants an evaluation for ischemia, like we talked about. There are many different ways that you can look at ischemia, such as stress tests or cardiac catheterizations. We should also be looking at and treating for any arrhythmias, whether it be atrial fibrillation, which is causing tachycardia, or life-threatening arrhythmias like a ventricular tachycardia that we need to be watching for. There are also many exacerbating factors for heart failure: poor diet and increased sodium intake, decreased activity level, drinking in excess of fluid. Drinking alcohol can exacerbate heart failure sometimes. We also need to look at comorbidities and try to watch for these. Many of these patients will have sleep apnea. Many of these patients are obese, and we need to work on these things. Many of these patients are hypertensive. A lot of them are diabetic, so we need to control these. And lastly, you need to be looking at any potential barriers for adherence for these patients. Sometimes they might not have insurance. They may be the primary breadwinner of their household and they can't take time off, so they can't come to your clinic appointment when you're only open from 8 to 5. So working with these patients to help with all of these things are also necessary in caring for these patients.
I would just add, in terms of that etiology, Terry, it is important to figure out what is the underlying cause of the heart failure. Patients always are surprised when I tell them that roughly 70% have ischemic underlying cause of heart failure, but there are 30% that it's more potentially related to a virus that has weakened their heart. And a lot of people aren't aware of that. In terms of the life-threatening arrhythmia, when the ejection fraction or pumping power of the heart is diminished, they're at much more risk for those life-threatening arrhythmias and sudden cardiac death, which we'll talk about more as we unfold this case.
When we talk about the pathway in which heart failure affects your body and all of your compensatory mechanisms, as your heart dilates out, it stimulates your autonomic nervous system, which stimulates adrenaline and norepinephrine and epinephrine. This then stimulates your beta and your alpha receptors. They increase heart rate, they increase blood pressure, they increase vasoconstriction. This can cause sodium and water retention. The heart does this as a compensatory mechanism to increase and augment your cardiac output so you get more filling. In addition to that, your kidneys are also stimulated to release more renin, which then causes more vasoconstriction and causes more work of the heart to give you more augmented blood pressure to increase your cardiac output. When we look at this, it's important to know these systems that are stimulated, because these are the areas in which we focus our medical therapy. We look at ACE inhibitors to block the renin-angiotensin aldosterone system, and we look at beta blockers to actually slow heart rate to allow some myocardial recovery. Some of the newer pathways that are being looked at are looking at neprilysin inhibitors as a way to decrease fluid retention and upregulation of heart failure.
One of the things I think as you look at this, obviously there are, as you said, Terry, multiple pathways affected here. And I think that's important to help patients to understand, because they often ask, why do I have to be on 3 and 4 different medications? And that's because we've identified specific medications, as you said, to block these various pathways and help the heart failure situation.
If John was in your emergency room, how do you think you would treat him? Some of the potential things that you could think about is, would you cover him for pneumonia? Start him on antibiotics, see how he does over the next 24 hours, and go on from there. You could also talk about treating his hypertension. He's hypertensive, so obviously that would be a good place to start. Would you ensure that he doesn't have an arrhythmia? Or would you just try with gentle diuresis, thinking maybe if you just got rid of some fluid, assuming he has heart failure, that maybe his breathing would get better? So when we look at John, when he presented to the local emergency room, as he was hypoxic, he was started on some oxygen. It was felt that, yes, he did likely have pneumonia, so he was started on Zosyn. With the chest x-ray showing the enlarged cardiac silhouette, there was concern that maybe he did also have heart failure, so he was started on some Lasix. And due to the hypertension, he was started on fairly significant doses of both carvedilol and lisinopril. The institution felt that he was a rather complex patient, and decision was made to transfer him to a tertiary care center for further evaluation.
So one of the other things in this management of John, the diuretic, the beta blocker, the ACE inhibitor, in addition to helping with the blood pressure, we have a strong suspicion of heart failure, partly because of that elevated pro-BNP level. And that's often one of the things you can look at in terms of figuring out whether this is pure respiratory versus potential heart failure, cardiac interacting here.
When John arrives to the tertiary care center, he's still short of breath. His physical exam hasn't changed much. He still has jugular vein distension. He still has ascites. Did not diurese much from the IV Lasix. He remains hypertensive with blood pressures in the 160s to 170s. At the institution, he gets an echocardiogram. On echocardiogram, it shows that his ejection fraction is 10 to 15%, with normal being 55% or above, and he has moderate right ventricular dysfunction. It also shows that he has moderate mitral regurgitation, which is probably due to his dilated left ventricle and is functional in nature, not something that is physiologic that may need surgery, but is something that we should continue to watch. He also has elevated filling pressures on his echocardiogram, with his pulmonary pressures of 40 to 45, likely due to fluid overload. It also shows on echocardiogram that his inferior vena cava is dilated and does not collapse with each beat. Now that you know John's echocardiogram and that, yes, he does have some sort of heart failure and a low ejection fraction, what would you want to do for John? Would you think about decreasing his carvedilol due to acute decompensation? Would you add some hydralazine and nitrates for vasodilation due to his elevated pulmonary pressures? Would you add some valsartan? Or would you adjust his diuretics to ensure he has a negative fluid balance? When I look at John, I think that the first thing that you should do is decrease his beta blocker. All studies will tell you that in a patient who has acutely decompensated heart failure, beta blockers actually increase mortality and worsen your heart failure. So the first thing we would do is take John's carvedilol either down to a significantly lower dose or stop it completely due to his decompensation. Another thing that would be very beneficial for him, looking at his echocardiogram and his pulmonary pressures, would be the addition of the hydralazine and the nitrates. These work very well for vasodilation in patients. They also make it easier to help diurese patients that have elevated filling pressures. I don't really think that adding valsartan is going to do anything. It is actually probably going to make his kidney function worse. He's already on an ACE inhibitor, and you don't need to be on both an ACE inhibitor and an ARB. The other thing you should also definitely do in light of his echocardiogram with elevated pulmonary pressures and a dilated IVC would be to adjust his diuretics. You want to ensure he's negative 1 to 2 liters a day, so making sure that you're able to get fluid off of him and follow his fluids throughout this day is very important.
Terry, I agree that carvedilol at the 25 milligrams BID is actually our target dose for people who weigh less than 185 pounds. So he had not been on it prior to that hospitalization. So that's a very large dose. Typically, we need to start carvedilol at a lower dose and then up-titrate to their maximum dose. And certainly, as you emphasized, in acute decompensation situations, even if they've been on the 25 milligrams BID for quite some time, we will decrease the carvedilol in that acute decompensated situation.
So now that we know John's echo and we've adjusted his medications, what would you think would be the next steps for John and his treatment plan? Some things we could discuss would be a left heart catheterization, a right heart catheterization, stress testing, discharge of the patient with prescriptions and follow-up, or repeat renal function testing. When I look at those, to me the first things that pop out are the heart catheterization. Should we be doing a left and a right heart catheterization? Some things to think about are the patient's renal function. Is his creatinine where you wouldn't want to be giving him the contrast, or do you feel that his renal function has improved enough to where you would be? Some institutions would be okay doing a cardiac MRI as a stress test to look at these patients, to look at ischemia. Here at Nebraska Medicine, sometimes we will do stress MRI if we feel that the creatinine is too high and they would put their renal function at risk. The gold standard for all diagnosis, though, is to do a left heart catheterization to see if this patient does have any ischemic causes for his heart failure, which can be treated. The right heart catheterization, I think, is also vital in these patients. No contrast is given, so there's not concern of renal function, but it provides a lot of information about their filling pressures, gives you a good sense of their cardiac output and index, can also help you to adjust medications if you think you're getting good diuresis, but their renal function is going up and you're questioning, do they have cardiorenal syndrome, or are they just so wet that I need to continue diuresing? When I look at these as discharge with outpatient prescriptions, to me that's not currently a good option, because we need to be looking at what are the causes and what can we fix for this patient. And yes, I would say renal function testing is very important, because when he came in, his creatinine was 1.6, but that's not necessarily the next step.
I would totally agree, Terry. I think you've discussed that very well. You really do need to understand what's going on with the heart at this point, and so that catheterization is critical. And being aware of what the current renal function is prior to proceeding with that and using contrast, as you mentioned. So
the decision was made to take John to the Cath Lab. He has a left heart catheterization showing that his coronary arteries are normal. He does not have any concern of coronary artery disease, so doesn't need a stent or bypass. His right heart catheterization numbers show that his right atrial pressure is 8, his RV pressure is 20, he has a wedge of 16, his cardiac output is 5.2 with a cardiac index of 4.6. When I look at these numbers, it tells me that in spite of a low ejection fraction, he does have maintained cardiac output and index, which is good that he may not need inotropes currently, but he does have a very elevated wedge, so he's someone that we need to continue diuresing while we closely watch his renal function. In all of this, we continue to adjust Mr. Smith's medicines, and we work on discharge planning. More than likely, this gentleman had long-standing hypertension, which has been untreated. There's more than likely chance that he's had high blood pressure for quite some time, as he hasn't seen a physician in 4 years. So it's suggested that maybe he has a hypertensive cardiomyopathy. You would also think that potentially he had a viral cardiomyopathy, as he had this respiratory illness, but the high blood pressure and as high as his pressures were the entire time he was there would lead me to more to think he has untreated hypertension as the cause of this. During his hospitalization, he was diuresed 10 liters. His discharge dry weight was 238 pounds. And this is especially important for all providers to know, whether you work in cardiology or whether you work in primary practice. If your patient has heart failure, they should know their dry weight. This is where we feel that this patient is euvolemic on the right amount of diuretics and where we try to always aim for. When we looked at his medications, he was sent home on small dose of carvedilol. He was sent home on hydralazine and Imdur in combination for vasodilation. He was sent home on lisinopril daily and sent home on Lasix. We always do a home needs assessment on all patients. So do they have insurance? Are they going to be able to pick up their meds? Do they potentially need home health? Do we need to talk about not working for a period of time? Do they have a physical labor job where they need to not lift things?
Those are all very key things, questioning them about their diet and what foods they like to eat. Invariably, somebody who has this history of hypertension, they like their salt. And of course, we want to try to limit the sodium. Also, it's amazing to me how many patients don't have a good scale at home to be able to weigh themselves daily like we emphasize to them. And I think really helping them understand the importance of that, and like you emphasized, Terry, knowing what their dry weight is, because that's the trigger for them then to call us that things aren't going well. When they see that weight go above that dry weight of 3 to 5 pounds, they know they should be calling you as the provider.
John now returns to clinic for his 1-week hospital follow-up. And these appointments are very important for patients when they're discharged from heart failure admissions. We want to have a patient seen within 7 to 10 days after hospitalizations, and there's multiple things that we want to be looking at, which we'll hit on here. But when he comes to clinic, his physical exam shows a blood pressure of 132 over 78. His heart rate's 86. His respiratory rate's 20. He's afebrile. His oxygen saturation are better on room air. His weight is up. He's 10 pounds up since discharge. He is weighing himself daily on his home scale. He is using the same scale as we instructed him to. He states his stomach feels a little more tight. He's a little more bloated. He can walk 2 blocks now without getting short of breath. His white blood cell count is 8.2. His hemoglobin, hematocrit, and platelets are all normal. His sodium is 136 with a potassium of 4.6. His BUN and creatinine have slowly came down. It's now 28 and 1.42 where he was in the 1.6 range, and now his BNP is 560.
Which, again, that's a pro-BNP. So if you're looking at BNPs, that's kind of right at that normal levels. But certainly what we want to look at is how it trends. We use the BNP more in a trending fashion. So if you remember, he was quite a bit more elevated.
Like 2,300 we had him when he came in.
So you can see that he's quite a bit lower in terms of that BNP, meaning that that's a good sign in terms of the amount of fluid on board.
So things that we look at in the hospital for our follow-up clinics, we want to look at his functional capacity and his activity level. So he told us he can walk 2 blocks without getting short of breath. We want to look at changes in his body weight. His weight is up 10 pounds from when he left the hospital, which is concerning to me. Is he following the diet like we're talking about? Is he following his sodium restriction, his fluid restriction? Does he understand what medicines he's taking? Is he taking his furosemide on an empty stomach, or is he taking it after he's eaten? Because the absorption of furosemide or torsemide is much better when it's taken on an empty stomach. So some of those little things in his medical regimen to know if he understands those. We also want to continue looking for any sources of arrhythmias. Has he felt like he's going to pass out? And are there any other things that could be exacerbating this? Does his wife notice him snoring at night? And we also need to send him for a sleep apnea referral. Is he still smoking? Or is he following the counseling we gave him when he was in the hospital?
So as Terry emphasized, this 1-week follow-up is really critical. And what always is amazing is when you do a medication reconciliation, invariably patients go back to what they were taking prior to the hospitalization. So even though things were readjusted, like we decreased the carvedilol in this patient because he was acutely decompensated, they'll go back to what they were doing before they were hospitalized. So you really have to, and we encourage them to bring in their actual pill bottles so you have them in front of you to go through. But that's probably the key thing, and what is always amazing to me is making sure they're doing what you thought they were told to do when they went home. I think the dietary thing, oftentimes when people come back in up in weight, it's always a good idea to ask them, what did you eat yesterday? And you'll get things like, oh, my canned soup, or dill pickles. I love dill pickles. And, so really asking them what they do helps them kind of learn also what to do and not do. I think your point, Terry, about the lightheadedness, oftentimes they'll come back in and say they're lightheaded. I think it's really important to understand, is that to the point that they felt they were going to pass out, and when did they feel it? Was it with a position change? For instance, they were lying down or sitting and they got up too quickly. That leads you to believe that it's more potentially just the change in blood pressure that happens with position change, as opposed to somebody saying, I was just sitting in my chair and all of a sudden this lightheadedness hit me and I thought I was going to pass out. That is much more concerning and something that we definitely would need to explore in terms of maybe getting a Holter monitor or an event recorder so that we could see what was actually going on during any episodes like that. Because as we talked about previously, these people are more prone to arrhythmias, and so we want to be particularly alert to anything like that.
At this point, we want to talk about medication optimization for John. So just think about some of the things that you would potentially recommend for John. For me, some things that come to mind is, should I increase his carvedilol? Should I switch his torsemide to furosemide due to weight gain and bloating? Should we start an aldosterone antagonist? Or should we leave things as they are and have him return to his scheduled intervals and follow up his adherence? When I look at those, to me, increasing the carvedilol is potentially a very good option. He has blood pressure room to do this. He's also slightly tachycardic. And when you talk about goal doses for beta blockers, you want to get these medications to the maximum tolerated dose. As he weighs over 200 pounds, if you can titrate him all the way up to 50 milligrams twice a day, you should. Now, you need to follow him regularly because he may become dizzy and lightheaded with this. You also need to watch for signs of nausea. Carvedilol is much better tolerated if eaten with meals. Beta blockers can also cause some erectile dysfunction problems in men, so it's very important to follow up on this, to ask patients about this, because you don't want them to stop taking the medicine because they're embarrassed to talk to you about it. I also think that switching his furosemide to torsemide is potentially a good idea. He's up 10 pounds in just 1 week. Some of that may be diet adherence, but some may be that he's fluid overloaded and maybe he's not absorbing the furosemide as well as he would the torsemide. Torsemide is much more bioavailable than furosemide, so it might be worth switching that. It will cost him a little bit more, so you should look into insurance coverage for that. Starting an aldosterone antagonist is also a good potential option when you look at spironolactone. That's something that could be started for this patient. He's walking 2 blocks and getting short of breath, so I would consider him a class 3 heart failure patient, and it's a medicine we should think about too. The option of just having him come back at scheduled intervals, I don't think is the best option because his medications need titrated, and this also gives you the time to teach him, like we stated earlier, about the multiple pathways in which heart failure affects the body and why we need to be on these different medications and different classes of medications.
So I agree with what you've said, Terry. In terms of increasing the carvedilol, obviously we want to get them to the max dose that the individual will tolerate. The research shows us that that's going to improve the functioning of the heart, and it's dose responsive. So you want to get that to the maximum dose possible. I think in this case you have to think carefully. Anytime you up-titrate the carvedilol, it can cause a little bit more fluid retention. So in this individual, how much extra fluid's on board, is he going to tolerate that? And so definitely, as you discussed, I think if you're going to increase the carvedilol, you need to also address the diuretic, because increasing the carvedilol will cause a little bit more fluid retention. So definitely need to do something with that fluid retention. In terms of starting the aldosterone antagonist, I'm not certain that I would do that at this visit. Certainly something to think about, but we know this individual had a little bit of renal insufficiency. Obviously, when you start the aldosterone antagonist, you want to recheck and make sure that their creatinine and their potassium levels are okay after you've upped that. So if you did that, you definitely want to bring them back in a week to 10 days and recheck renal function and that potassium level. So I agree, just sending them home to come back later without doing something at this point would not be a good option.
So when we look at heart failure, we talk about it in stages and classes, and we want you to know that you have both your New York Heart Association class, which is functional, and you have your American Heart Association class, which looks at both the structure of the heart and how they function. The guidelines then also lead to you determining what therapies patients should be on based on their functional class and their stage of heart failure. When we talk about medications for heart failure with reduced ejection fraction, the guidelines are published through the Heart Failure Society of America and also in conjunction with the American College of Cardiology. The medication classes that we use are the ones that we've talked about before. We use ACE inhibitors, we use ARBs, we use aldosterone antagonists, we use beta blockers, and we use hydralazine and IMDR. The ones that are listed are the ones that have been studied in trials and are approved as heart failure medications to actually improve outcomes and improve cardiac contractility.
One thing I would add is please note that this is reduced ejection fraction, and that's the case of John. He's reduced ejection fraction. We don't have the same research evidence to guide us with what should be done in the case of preserved ejection fraction. So just to point that out.
And this gives you a list of all of the medications by name and different doses. And as you know and can see, these doses should be targeted to the highest tolerated dose. And you don't just want to put patient on a low dose and say, I've got them there. You want to titrate it up as high as you can. And you want to do this at regular intervals. And every time they're at the visit, look at the doses and see if something can be adjusted. And as Bunny said, there are currently no guidelines for treatment of heart failure with preserved ejection fraction. All of the guidelines will state is that you should treat any underlying comorbidities. So if you have hypertension, you should treat diet hypertension. If you have sleep apnea, they should get treated for sleep apnea. But there are no current medications that are approved at this time to improve morbidity and mortality for heart failure with preserved ejection fraction. The newest treatment guidelines for heart failure came out as an addendum in 2016 with the addition of 2 new medications. The first medication is an ARNI, which is an angiotensin receptor neprilysin inhibitor. It combines an ARB and a neprilysin inhibitor. The medication right now is valsartan sarubritrol. It is a twice-day medication. One thing that I would say with this is when you start a patient on this medicine, you should watch for low blood pressure and also decreased need of your diuretic, as the sarubritrol will cause a diuretic effect. So you may need to lower their furosemide or torsemide. The other new FDA-approved medication for heart failure is ivabradine, which is a direct H2 blocker, and it is indicated for patients who are tachycardic on maximum tolerated doses of beta blockers. This is contraindicated for a patient in atrial fibrillation or a patient who is pacemaker dependent, and you should get EKGs to follow up on heart rate and to watch for heart blocks so that the patient may not need pacemakers. Back to John. He's now been out of the hospital for 4 months. He's here for his follow-up visit. His physical examination shows that his blood pressure is 98/62. His heart rate's now 76. His oxygen saturation is normal. His weight is 246, and he continues to call regularly with fluctuating weights and occasionally needing more diuretics. And if you'll recall, at discharge, his dry weight was 238 pounds. If you look at his medications, we've got him titrated up to carvedilol at 50 milligrams twice a day, which is the dose he should be at. He's on lisinopril, 20 milligrams a day. He's on torsemide, 20 milligrams BID due to the weight fluctuation. And we've also added the aldosterone antagonist, and so he's on the spironolactone at 25 milligrams daily. So he's on good medications. He's been following up regularly. To me, when I look at this, what's concerning is he continues to call with fluctuating weight gain. So it's a question of, is it diuretic resistance? Is he not adherent to his diet and fluid restriction? And is there something we can do to help manage this better on an outpatient setting for him?
And this is where I really emphasize weigh yourself daily, and if you gain weight, gain 2 pounds in a day, think back to what did I eat yesterday. You probably ate something that was very high sodium. The other thing I don't think we've talked about is spacing of medications. The carvedilol is a BID dosing, the lisinopril is a once-a-day dose. And so because they both do affect blood pressure, patients sometimes will tolerate better if the carvedilol is usually AM after breakfast and PM after the evening meal. So lisinopril is better probably at noon or bedtime so that you offset those blood pressure medications.
So now that we've had John on optimal medical therapy for his 90 days, we need to repeat his echocardiogram. His echocardiogram shows that his ejection fraction is 25 to 30%. His RV function is now normal, and his pulmonary pressures are 35 to 40, and his IVC is dilated. To me, the things that pop out on this is his ejection fraction still hasn't recovered to normal, and his pulmonary pressures are still slightly elevated.
And we haven't considered what is normal. We typically say if it's 50%. Is that kind of what you use as a guide, Terry?
We typically want people 50 to 55%, but he's definitely not back to the normal, and he's been on the medications long enough where you would anticipate if he was going to have recovery, he would have recovery by now.
Right. It's typically 3 months that you give them on the carvedilol to see the beta blocker.
And looking at that, he's been on the medical therapy for 90 days, and his ejection fraction is still less than 35%. So you should refer him for possible ICD placement. When we look at indications for ICD therapy, it's anyone who has been on medical therapy for 90 days that their ejection fraction remains less than 35%. So he's someone that should be set up to see an electrophysiologist to determine if he needs a defibrillator. For people in the primary care world, you should be remembering that I need to make sure my patients had their follow-up, that their ejection fraction has been reassessed after the appointment, that they've gotten at least an echocardiogram once they've gotten on medications. The other potential referral that I would send this patient is for a CardioMEMS device, and we'll talk about that a little bit later, but CardioMEMS is a device to help monitor pulmonary pressures to help guide medical therapy for fluid retention. This patient also got a cardiopulmonary stress test, which is a metabolic exercise test which shows functionally how well you're doing. It measures oxygen consumption and then calculates that based on your age and your weight and it calculates for normals. His oxygen consumption was 22.4, which is 70% of predicted. We consider normal 85 and above. And we consider less than 50% of predictive to be poor prognostic. So he's doing fairly well from a functional capacity. It's not normal, but it's near normal. On top of that, he's on good medical therapy, so I wouldn't recommend changing any of his medications at this time.
I would agree with all of that.
So these are the guidelines that we talked about on the last slide before. For anybody that has a persistently low ejection fraction, less than 35%, they should be referred for evaluation for ICD therapy. They should also be evaluated to see if they would qualify for a biventricular ICD, where they pace both the right and left ventricles if they have a bundle branch block. This is the continuation of the guidelines looking at bundle branch block and if they need a biventricular ICD. The other thing that I think that we should point out is that ICD therapies are contraindicated for people with chronic severe heart failure with a life expectancy of less than 1 year. So that is level of evidence C, but it is still recommendations that if they have another comorbid condition and their life expectancy is less than a year, you would not refer for ICD therapy. This is just an EKG. It's looking at a bundle branch block in a patient that would meet diagnostic criteria for a biventricular ICD, so you could pace both the right and left ventricles to get better synchrony between this and try to improve overall cardiac output. The other device that I talked about a little is the CardioMEMS device. It is currently the only FDA-approved device that can be used at home to measure pulmonary artery pressure. It is implanted via a right heart catheterization, and it has a sensor, so there's no battery. It sits inside the pulmonary artery, and patients at home can use their monitor daily to download their pulmonary artery pressures. We use this as a way to guide their diuretic regimens, to look at fluid retention, and to look at trends. The study in which the FDA looked at this to approve it showed that there was upwards of a 50% reduction in hospitalizations for heart failure patients. And this therapy is actually approved for both heart failure patients with reduced ejection fraction and preserved ejection fraction. It's one of the few therapies that we can currently use for preserved ejection fraction. In summary of John, he presented to us about 4 months ago. He was acutely short of breath. We did a comprehensive evaluation looking at both cardiac and pulmonary causes. He had evaluation showing that he did not have any coronary artery disease and was treated as a non-ischemic cardiomyopathy. He was on guideline-directed medical therapy. It's very important to have close follow-up after the hospitalization, which leads to success. The more you can see these patients and start as soon after hospitalization to go over what their medicines are, why their diet restrictions are important, why their fluid restrictions are important, are very good. Every time you see a patient, you should be assessing their functional activity level. If they can walk 2 blocks or 2 miles, it's good to know so you can compare for changes in there. We also talked about the need to refer patients for ICD therapy after they've been on medical therapy for at least 90 days if their ejection fraction doesn't improve above 35%. And the CardioMEMS device is a device that can be used for outpatient monitoring to look at pulmonary pressures and to help prevent rehospitalizations.